Welcome to the podcast and video interview of the Cleft Palate Craniofacial Journal. I'm Pat Chibbaro, nurse practitioner here in New York. Happy to be your host. And I'm really excited to have a conversation with the lead author on this paper. And it's the first time I've ever done a podcast. I think I've been doing this for like 5 years now. I can't believe it. And uh, and I actually and just FYI, the first podcast I did was with Dr. Oksana Jackson, who's now our ACPA president. So I just thought I'd give a shout out to Oksana. But this is the first time I've done a podcast on a letter to the editor. And I'm really excited about it because I think it does, as Ryan, the first author, said, it brings out a lot of, it gives you an opportunity to have a lot of discussion, which I think is awesome. So you can find it OnlineFirst. I just looked it up. It's the very first page. It's the last paper on the bottom of the first page of OnlineFirst because it came out just about a couple of weeks ago, February 19th, I think. And the paper is Addressing Cleft Care in Low and Middle Income Countries Beyond Cleft Lip and Palate with Improvement of Otolaryngology, Audiology, and Speech Services. And this is a group effort of Dr. Ryan Belcher, Dr. Krishna Patel, Dr. Jackie Clark, and Sarah Horn, and they represent from ENT, audiology, and speech language pathology from Vanderbilt, from the Medical University of South Carolina, from University of Texas at Dallas, and also from Smile Train. So this was quite a joint effort, and I'm very interested in finding out how this group got together, and why they decided to send a letter about this. So I want to welcome Dr. Ryan Belcher. Thanks so much for joining me.
Thank you, Pat. This is a very wonderful opportunity to get to talk about something that I'm very passionate about, and something that, again, I felt impelled to write the letter to the editor about. And so this is a great opportunity for discussion around this to be had.
Great. So always my first question is, what motivate? Well, let me ask you this first. How did this diverse group from different sites get together? And then on top of that, then what motivated you as a group to put this letter together, which is very comprehensive? I mean, it's not just your little couple of paragraph, response to something. It's really quite detailed. So let's jump in on that.
So I think the impetus is that I'm a pediatric ear, nose, and throat surgeon that does cleft and craniofacial care. So I'm a little biased in how I, view the landscape of cleft and craniofacial care from that angle. Not biased in a bad way, but pay attention to where ENT is not being represented. And one area, and I'll call out Smile Train a little bit in this, but if you look at the Smile Train board or their medical advisory board, there's no otolaryngologist on that group, despite an otolaryngologist has to be on every ACPA created team, despite almost 100% of kids having otologic problems with whether it's eustachian tube dysfunction, fluid in their ears, hearing loss, and the speech and language intertwine that otolaryngology represents as well. So because of that, I had formed a relationship with Sarah Horn, who is the director of the speech and actually audiologic services for Smile Train, which Smile Train recognized on their organization that is something that they were lacking with their global approach, and had hired that position within the last, I think, 5 years or so. So again, they recognized that, hey, we're pushing forward cleft and craniofacial care. Hey, here's another aspect that we haven't really developed, and so let's create a director position for that and really start pushing that conversation forward. So because of that, Sarah and I had become colleagues and discussion, and we actually, this paper or letter had been presented as a panel at the ACPA national meeting last year in Denver. So the ACPA, we submitted it for a panel presentation. ACPA felt it was important enough to have, and so this team that put together presented on the different aspects. Jackie Clark got involved because she is a past humanitarian award winner for the the Academy of Audiology. Hopefully I don't butcher that too wrong. And so she has some global health experience with audiologic services. And so she brought an expert opinion on that aspect. In fact, ACPA lacks a little bit with audiology memberships, and so it's really hard to find someone that's actually involved. I know our audiologist at Vanderbilt is, but others around the country, it's really hard for them to get involved in cleft spaces. So, and then Dr. Krishna Patel, she is a board member on ACPA. She is a facial plastic surgeon at Medical University of South Carolina, and is really involved with Global Smile Foundation and on one of their boards for global health endeavors. And so, felt like we were bringing everybody together. The reason why we chose all three of these is that the communication sciences is what these three entities get grouped at often. And there are some otolaryngology departments around the country that involve all three of those. So, for instance, some ENT departments are called the Department of Otolaryngology with Communication Sciences, and they have audiology and speech language pathology within the department themselves. And so, we see these three as a intertwined group that you can't really do one without the other. I do want to make the point that there are other services that need to be done. There's dental, there's orthodontics, there's things like that. Don't want to talk about this at the expense of them, but this is just where we were, dialed in on for this paper. So.
Right. I mean, we know that, just speaking about orthodontics is such a challenge here in the US. Can only, you imagine what it is in some of these, developing countries. So then talk about this, this letter, this very comprehensive, very, really thoughtful letter that you put together. Why did you do it as a letter to the editor? And then maybe we can just talk through the things that you as a group are concerned about, and then you had a lot of ideas about how to how we can help, how can you improve those services that are certainly lacking in these countries.
We really aimed for the letter because we felt like this is more of a conversation than it is a new information. So certainly there are otolaryngologists publishing on this, there's audiologists publishing on this, there's speech language pathologists, but very rarely are there all three together coming together with their data, with their suggestions, with their recommendations to improve these aspects. And technically, it's a letter because we're not presenting new information in this, more so conglomeration of all the discussions that are being had out there. And, I think from the impetus to us is that we wanted to speak in, at least from an ENT side of things, that this is not an advocation of ENT needs to do more cleft. This is, hey, there's more aspects to it. And so than just the primary lip and palate. And I think that can sometimes get lost as, we've pushed the specialty forward, not we as an ENT, but as a group, as ACPA, as other organizations have pushed the specialty forward over the last 30 to 40 years. And I feel in my own global health experiences that, hey, we're kind of catching up with lip surgery around the world. I've seen a Kenyan orthopedic surgeon do a beautiful cleft lip repair. And I think that is the part where we're kind of not treading water by any means, but we're getting a little bit caught up on being able to address some of these primary things. But it felt like there's a lot of secondary aspects that get left behind, not just from a global health perspective, like mission trip, but hey, the in-town or the in-country team is not well equipped for these things either. And so it felt like this is a great time for us to start caring about that as a specialty, as an organization, as researchers.
So then the next question becomes how, well, let me step back. Talk about the things that you identified as some of the deficiencies in terms of, you mean, just simple things, but the fact that there are so few audiologists in some of these countries, period. That the ratio of audiologists to people is just minuscule. And I guess the question is, how do you address that? And do you address it? I mean, you've got the Global Smile Foundation, you've got Smile Train, you've got the ACPA, other organizations. How do you sort of come together to address it? And you came up with, you had some ideas. You also identified some of the things that Global Smile and Smile Train are doing. So maybe talk, for the people that are listening or watching that don't know, I learned a lot just from reading this in terms of what is actually happening. But talk, just maybe give us a bit of an overview about that.
Absolutely. I posed a question in there of, are we doing enough if a child's cleft palate or cleft lip is repaired, but their hearing loss is never addressed? The data says that 95+% of kids at the time of palate repair will have fluid in one or both ears.
Right.
So they have conductive hearing loss that potentially is not ever being addressed. And if you play that out for permanent conductive hearing loss, that has enormous impacts on their financial independency in the future, for their speech and language development, which again plays into the speech aspect. There's data showing, and Smile Train took some of their data and published it, and they showed that hypernasality presence was over 30% of cleft palate repairs from some of their surgical sites, with articulation defects as high as 94%. So these kids, again, we're doing the surgery, but if we're cleft surgeons, are we okay, or even surgeons on the aspect, are we okay with letting those high percentage issues continue to propagate without us having a plan to try to address those? When it comes to addressing them, there's a couple major problems. One is the lack of providers in each country. Not only lack of providers, but lack of training programs. So sure, you maybe have 10 audiologists, but who's replacing them when they retire, when there's no program in a high volume country? And certainly if I had the right answer and I could fix it, you and I probably wouldn't be talking here, and I'd be a minister of health somewhere. But unfortunately, I talk about the NGOs, or the non-governmental organizations of Global Smile Foundation and Smile Train, but I don't want to. I'd be remiss to say if there's not others out there doing this. I think it just happens to be the ones that we mentioned from some published data. But there are several suggestions on in the literature, and even on our own suggestions to address this. And one is increasing the qualified surgeons in local training programs, which makes a lot of sense. And then improving the cleft lip and palate education and surgical skills through teaching and local surgeon empowerment. Now, how can you do that? There's a few different ways. First is through a task sharing model. I think many people may be familiar with this, whether that's through community health workers or teaching general practitioners, nurses, and community health workers to provide some level of care. Now, surgery-wise, that may be impossible, but being able to, maybe you have the equipment for audiology, and maybe it's stable, we have a way of repairing that, etc. It doesn't always have to be an audiologist to instill that newborn hearing screen, or be able to do a automated brainstem response test. Now, audiologists, certainly we would prefer that, but there's a lot of instances in literature out there showing community health workers being able to give a test, particularly a app-based test with local empowered technology. Hey, are these kids passing their tests? If not, if they don't pass, maybe we need to refer them to the urban center where there are licensed trained professionals that can further investigate this issue for them. The second thing I talk about with surgery aspects are simulator models. So Global Smile Foundation has put on simulation camps for cleft surgeons, and there's a lot of great 3D printed cleft lips and cleft palates that they can train on. But at some of their simulation camps, they teach speech language pathologists how to use a flexible scope, how to evaluate anatomy of the velopharynx on top of their speech assessment. So it's not just surgery. And then that's a cleft specific simulator training, but within otolaryngology itself, they have developed otology based simulator trainings, whether that's learning how to put in an ear tube, which simple overall surgery, short period of time, but could have large effects for hearing loss in the low and middle income countries. So teaching a local ENT to do an ear tube and actually giving them the equipment to do that, and because sometimes the training for ENTs in low and middle income countries is bereft of that. That's how hard it is to get ear tubes, to be able to follow these, and we take it for granted here in the United States. There's also temporal bone simulators, so learning how to drill a temporal bone for otologic disease such as cholesteatoma, or if getting to the point of implants like bone anchored hearing devices is this totally next level on
Yeah.
technology service aspect. But I guess from the otologic standpoint, just from a cleft standpoint, there are ways for us to empower the local otolaryngologist, but we have to really invest in the training models as well.
So, wow. Yeah, I mean, it's a big, it's a big need, obviously. And I'm thinking, uh, you mentioned an orthopedic surgeon that, was able to be trained to do cleft repairs. I would hope that, being trained to put ear tubes in would be something that, would be, if you could achieve what you've achieved, that should be achievable. I guess my question is when you get into the audiology, I guess my feeling is, that's more sophisticated training, and then you have the issue of, do they actually just physically have the equipment,
Hmm.
and so I know those are big challenges because it's true, you get those ear tubes in, you can solve so much of their problems, but you then still have to follow up, because some of the kids need a second set of tubes or
Yeah.
maybe sensory neural hearing loss. So it's a big challenge. So are you thinking, I'm thinking to your future, with this. You've come up in this letter with a lot of suggestions. What's your next step? What what does your group or others, think about? What are your plans about, really trying to make some of these things happen?
Yeah, I think if it's not top of mind, it's really hard to make those changes. So this is a first step. And one thing about global health, whether it's marketing, whether it's you advocating for what you believe in, you can't really sway people. You can't really sway funding without data. And I think to me, one of the goals with this was to present data to show that this is a problem.
Yeah,
And you can reference this and say, this is data. And that's what you talked about. Like, it's got, bunches of references to support some of the data things that we're trying to advocate for, and not just saying like, we're not just screaming, hey, this is a problem. I know we can't prove it, but yeah, I think that that's kind of the first step. The
right,
next thing is that, and I, for all people involved within Cleft Care, is to care about this, um, and for ACPA to care about this. And as we go on surgical mission trips, and hopefully these involve empowering local surgeons and local providers, be like, okay, well, we've been training the surgeons here for 10 years. What let's bring in information on how to educate for speech and language problems. Now that we've been coming for so long, now we have 10-year-olds that have hypernasal speech and need education on training on that. Oh,
right,
actually, here is, and I would be remiss. Smile Train has started to put a lot of effort into this. They've had hosted almost like global boot camps virtually for local SLP providers to, as you mentioned before, that there's some a lot of speech pathologists here in the United States that don't understand cleft care. And you got to think that in these low and middle income countries, if they do have speech and language pathologists, that cleft care is not their main priority, but having some information involved with that. And actually, the Smile Train website has resources on their website for a wide variety of language for speech services. So they have like 30 plus languages, including Spanish, Hindi, French, Mandarin, Portuguese, that are accessible for local SLPs to do teaching in their own local language. So it's not a always English based thing. So what is the next steps? Us to care about it, not just me, but hey, a plastic surgeon that doesn't is not an ENT, that is not a speech to English pathologist, but start thinking like, okay, let me incorporate this part of my care if we're going to really approach this whole patient. And then the NGOs is kind of the next level. Hey, if they do have training sites and it's just surgeons, maybe we look to add a local training program for speech language pathologists and audiology. Maybe we get that technology that is needed there and train the community health workers to be able to understand hearing loss. What should we do? Oh, this person has hearing loss. Let's funnel them to the right person. Let's get them the otologic surgery that they need. And then, next tier is country buy-in. I think that's that's always hard. There's no doubt about it. Ministries of health are really the main players, and sometimes there are regimes and political concepts that create a lot of turnover in that position. So you may have one minister of health that cares about this, and then they've switched over positions within a year or 2 years, and it's really hard to sustain momentum. And so I see the NGOs as having that sustained momentum, and then local providers, sometimes working outside the health NGOs. I work with an anesthesiology team here at Vanderbilt that cares a lot about training East African anesthesiologists, and so they've done a wonderful job of building up the infrastructure for anesthesiology in Kenya, out of Kajabe, Kenya, and they are creating anesthesia training programs in Ethiopia, Tanzania, but he's been doing it for 30 plus years. That's not he started yesterday and got into those countries,
right?
And so it's a long game here, and that's the goal.
As you're talking, I'm thinking, having been involved with the ACPA for so many years, over 30 years, and knowing that, talking about mission trips, do you have a handle on how many different organizations are going out in this world doing these mission trips? Because when I think about it, to be able to really get a handle on how many are there, are they all seeing the same issue? How can they all work together? Because it's just mind-boggling to me. Every time I talk to someone, they're on a different organization going on a mission trip doing Cleft Care. It's just all over the map.
Right.
I wonder, and they must be, and I'm sure that they must be identifying this same issue. So I wonder what do you see, just in the future with, if we're going to make a difference on this, that we're really making a difference all over.
Great point. And, I think that I know from an otolaryngology standpoint, we are trying to collate some of that. So our Academy of Otolaryngology has a cleft and craniofacial committee that we have our shared surgeons together, trying to put our heads together for these kind of concepts. Again, it's starting with data. We recently did a survey, and hopefully to look to publish that in the near future, of ENTs, and that's pediatric otolaryngology trained cleft and craniofacial surgeons and facial plastic specialty trained surgeons. How many of us are going internationally? What organizations are we using? How can we coordinate with, even though we're in different organizations? And there's like over 40 different organizations involved in that. And then you take in, many of the plastic surgeons that I know that involved at ACPA, they go on their trips as well with different organizations, sometimes overlapping with ENT. And, you got to assume that there's, 50 plus different organizations involved with, at least from a cleft side of things. That may be that's probably underestimating it. If there's not a conversation about this, if there's not letters to editors emphasizing this, if there's not panel presentations on this, it doesn't get organized. There's a ACPA humanitarian efforts, or a surgical global surgery special interest group. Is that a forum which that could, organization could happen potentially? It does get really hard for, and I can't speak for the ACPA themselves, but they are a nonprofit organization. So them sponsoring NGOs, or, it gets a little tricky with who do you support, who do you not. And so a lot of times, a lot of national organizations tend to kind of stay hands off on that aspect. But there are the special interest groups where that they can, non-affiliated people can put these organizations together in a room to discuss how can we all address this, and put our powers together for that. That'd be my, $10 million answer for that, but it'd be nice.
Yeah, I mean, it's a huge, you've identified a huge deficit around the world, and I guess my thinking is, that the ACPA is probably the place that has the people that are going on these trips. And so anything if your SIG group can do, I think, to put more focus on really figuring out, and there are things that can be done, and it's a big, you've identified a huge, it's almost like the issue of insurance coverage for, cleft and craniofacial orthodontics, like
Yeah.
that's one. It's like, well, the ACPA needs to deal with that. And yeah, but it's huge. And
Right.
I think
Right.
that, we just really, I think what you've done, is important. And I hope that there's more. Do you feel that when you get to California, if you're going to the meeting in Palm Springs,
Yeah.
is this something that you're hoping to try to, work on while you have that sort of captive audience? I don't know if you've submitted anything else on this.
No global health stuff this year. I do have a couple a oral presentation and a couple poster stuff, but I'll be at the special interest group meeting, and anybody has any passion towards this, happy to talk to them about it. I think that's the cool thing about ACPA is that I don't not claiming to be an expert, but there's a lot of people involved with ACPA on all subspecialties that are global health minded. And so I think this has just the topic itself has a lot of motivation and a lot of people that are very well versed in global health endeavors that have a lot that may be in charge of their own organization, that has their own nonprofit that can make these sweeping changes. And so I would just encourage anybody in that realm to be passionate about this too.
Definitely. So before I wrap this up with you, any other thoughts, anything you wanted to share with anyone who's listening or watching?
I think the paper speaks for itself on how I feel about this, but I think again, re-emphasizing that ACPA is I mean, I would almost put a bet on that when it comes to member involvement on the amount of people that do global health, do global surgery, have humanitarian efforts involved. I would put ACPA as one of the highest percentage ones in the medical subspecialties. And so I would just emphasize to keep this top of mind for those that are going on trips to be like, okay, well, let me actually go to the Smile Train's website and look at what special speech services they do have to offer for local empowerment. How can I think about doing that on my own cleft trip? And this doesn't, even if you're a medical student, you could do this.
Mhm.
It's not a matter, it has to be the lead person of every organization. And so I think there's just a lot of ways to slowly, find ways of improvement for this. And then I think this is, it can be an epidemic in a good way, as it slowly takes over. Everybody has this involved in their trip. And then, like, that's a totally different conversation 10 years from now. If everybody's doing this, well, local growth continues to happen. And then we find ourselves in a good place. So,
Well, good work, and I am, let me just for everyone, to, make sure they can see this, in, OnlineFirst, letters to the editor, February 19th, I think it was published, but it's on the bottom of the first page of OnlineFirst, addressing cleft care in low and middle income countries beyond cleft lip and palate with improvement of otolaryngology, audiology, and speech services. Ryan Belcher, Krishna Patel, Jackie Clark, and Sarah Horn from ENT and facial plastics and audiology and speech. True team effort. And I'm really, I was really impressed with this, Ryan, and the very thoughtful and lots to think about. And just congratulations on putting something like this out there. And hopefully you're going to get a lot of discussion. Lots of people are going to come up to you at the meeting in California and talk with you about how we can improve this around the world, these services. So thanks so much for joining me. Really appreciate it.
no, thank you, Pat. Awesome.